I am Dr. Brett Greenberger. This is Emily Greenberger. We own and operate CCTMS together, and we have a nice team here helping us to do this work. So
I'm going to say, who is Dr. Brett Greenberger? You don't have to introduce yourself. Who is Dr. Brett Greenberger? So he is a board certified child, adolescent, and adult psychiatrist. Studied at BU in their 7-year combined bachelor's MD program, and then went on to do his residency and both fellowships at the University of Maryland. Has extensive experience in lots of different locations, from emergency room settings to outpatient mental health, intensive outpatient, and now all outpatient work. He is the medical director of Collaborative Counseling Center, which he mentioned before, which is primarily an outpatient center helping children, adolescents, adults, where he does psychopharmacology for all of those populations of people. And how many years ago was it that you began Collaborative Counseling, TMS?
So TMS is about to begin our 5th year here, which is a separate entity. It is its own business. It operates independently, and it has its own team. It has its own team meetings that we operate here, where we discuss and collaborate the care for the patients that are actively reaching out to us regarding TMS and learning about it, patients that are in ongoing care receiving TMS. And we do some outreach afterwards as well, kind of following up with folks to kind of see how things are going for them after they've completed a course of TMS. Mm-hmm. So, Emily shared of my experience. I'm not sure how many of you know me, how many of us have actually, how many times we've spoken. I'm sure I have spoken to some of you in the past, collaborating care and coordinating things. My work here in Howard County even began during my residency, where I was located over at Humanum, was my internship location. I do also live here in Howard County, so I'm very familiar with this community. My work at Howard County General, I did emergency room work, coverage for the emergency room and over weekends and nights, taking care of folks on the unit as well for several weekends per year. So, in the care and keeping of some of the more severely ill patients that we treat in the community.
Well, and I'm here because I'm a therapist and I treat children and adolescents and adults, but really joining Dr. Greenberger today for the presentation, because as a therapist, I did not know what TMS was or how TMS could be helpful to the clients that I work with. So I've learned a lot, and I wanted to sort of be here as a therapist speaking to the kinds of clients that I referred to TMS and what those outcomes look like. And also I've been in the room treating TMS clients and sort of what that looks like juxtaposed to my position as a therapist. So thank you for having me.
Terrific. And let me jump slides here. So, what is TMS? What is this? And so what we've got here is, this is a person sitting, and there's a coil kind of up next to their head, which is a magnetic coil. And so TMS stands for transcranial magnetic stimulation. And this is a process where magnetic pulses are delivered to a specific region of the brain to activate it, to get things flowing, to open up neurotransmitter pathways, to create a depolarization in a specific location of the brain. It's the left prefrontal cortex. And this is a newer treatment. It's been around for a long time now, actually, and but the data is just growing for how effective it is, and the barriers to providing it are coming down. It's getting easier for folks to be authorized. Here we have at the bottom of this slide, TMS is indicated for adults with major depressive disorder that have failed one antidepressant of adequate dose and duration. Years ago, that number was 4, and different insurance companies do have different lines. There are some patients that still need to have tried 4 medicines or two medicines and an augmenting medicine, but a lot of the data now is supporting its effectiveness earlier in the course of treatment, so folks don't have to suffer and go through so many failed attempts of medications before moving into this non-medication treatment for depression.
Dr. Greenberger, what defines a failure of medicine?
So a failure of medicine would be being at a good dose for a good duration of time and continuing to have significant symptoms of the depression where either they have moved to a milder state of depression but are not in remission, or have failed to change the state. So if they start moderate and they stay moderate, that would be ineffective. Another thing that will be considered as a failed attempt would be a trial and somebody experiencing a significant side effect that prevents them from remaining on it for a more prolonged duration or getting to a significant dose. If somebody tries low dose of Prozac and experiences significant irritability, worsening mood, worsening symptoms of emotional dysregulation, then that would be considered a failed attempt also. That medication would count for insurance company purposes as a failed attempt. Good question. Thanks for bringing me back.
Always.
And let me jump to our next slide here, just kind of reviewing a little bit, even, what we're treating, who are we trying to help here? And so just kind of, bringing back up, just putting up the criteria for major depression. And really, it's always, still, I've been practicing for decades, but, the idea of severe symptoms for at least 2 weeks, I think many of us, 2 weeks is what? Like that's all it needs to be to meet criteria for a major depressive episode is a number of symptoms for a 2-week duration of time. The patients we're talking about, the folks that we are thinking about, have certainly been struggling for at least that long. Many of them have been struggling for many months or even years. We have treated folks here who had struggled for, I could say, decades of continuing depressive symptoms interfering with life and wellness that have benefited significantly from TMS and able to get into remission and really, changing lives. I talk to folks all the time about TMS and about, whether it might be appropriate for them. How can I help folks to achieve remission from depression? I think it is important for us to think about that word and to think about what that means to get into remission. I had a visit yesterday, actually, with a 17-year-old who had come in really struggling with significant symptoms and even some dissociation, a little derealization, in addition to the standard symptoms of depression. And we worked together. She was seeing a therapist, coordinating care, got her into remission. And then we were able to very gently taper her dose of Lexapro down. And yesterday was actually the follow-up that I had about 3.5 months after we stopped her final dose. And so she finished the end of junior year of high school, had the summer, is now applying to colleges, and yesterday's follow-up was to kind of make sure things were still good, that she was still in remission. Happy to say this was not a TMS patient. I'm bringing her up because of the discussion I also had with mom at the end, which was reminding them, talking with them, speaking with them about challenges, about emotions. There are going to be low moments. There are going to be anxious moments. There are going to be nights of poor sleep. We have symptoms. Folks can have symptoms without the overwhelming state of depression where the symptoms are the default, are the predominant state of existence for folks. And, the mom was very appreciative for me kind of reminding them of the range of emotion that is normal to feel, that is not only normal, is healthy to have the range of emotion. I know, Mark, you guys in the DBT program in particular, really helping folks to learn to experience emotion, to tolerate uncomfortable emotions, and to be able to bounce back from situations and things that throw them. These folks we're talking about, these folks we're considering and thinking about for TMS, are folks that really have struggled with the bounce back. You know, something throws them and they're off for months at a time. That's often one of the things I'm looking for in my follow-ups with folks, and folks that seem to be responding well to treatments, is that they can bounce back after stressors, after something does throw them. So this was just kind of a little review. I also threw in here, where is this? Dysthymia, you know, because I think it's a challenge sometimes. You know, dysthymic disorder, having symptoms most days for at least 2 years. Now, I shared of the patient who had been struggling with depression for decades and got into remission with a course of TMS. There was likely a dysthymic disorder present as well, a double depression. Presence of mild symptoms continuously and superimposed more severe states of depression. TMS right now is indicated for major depressive disorder, but I would, you know, put out there for consideration. Sometimes it is hard to separate out kind of which group are we treating, what is the origin of the depressive process. Has there been a dysthymic disorder present for a long time, and now we have a superimposed major depression? When someone goes from wellness to depression, early on, you know, looking at those symptoms, you know, thinking about folks, we can move from severe to moderate to mild. But mild depression, when someone's coming in telling you they've been like this for many months, for an extended period of time, you know, separating that out from dysthymia can be a challenge sometimes. And so really, I try to look at periods of wellness. I strive to help folks think about, you know, a period of time where they were in remission, and is this another episode, or has there been a more continuous process throughout? And TMS is a treatment that helps the state of depression. It helps the neurochemical brain state of depression to get out of that state and to be able to function well again and in a healthy way. I've got a slide coming up. We'll show that a little bit more. And so NeuroStar TMS is the treatment that we are providing. And, you know, just kind of looking at these two sides here, the most common side effect from the TMS, and really it is fairly common here. The slide is talking, some patient, you know, will have discomfort up here on the left prefrontal cortex. This is kind of the area where the pulses are being delivered. And that's up to 50% of folks on the first day of treatment. However, by the end of 5 days, that number is down to 5%. So even that side effect, even that discomfort that can occur at the beginning of treatment, and I always love when I've got folks, because I prepare everybody for this. I tend to be one who over prepares for every possible side effect that could happen.
Yes. Just
by, you know, the nature, I tend to be very risk averse and trying to help avoid all risk. And so I prepare everybody for that. And it's always exciting when I have folks who are like, yeah, I'm okay, I'm good. You know, the 50% that really just don't have much discomfort, even on that first day. Mm-hmm. We have never had somebody stop a course of treatment for the discomfort. Mm-hmm. We can kind of compare that to various side effects that folks commonly experience with medications, whether difficulty sleeping or feeling too tired or headaches, dry mouth, some nausea, upset stomach, diarrhea, constipation. You know, there's a host of side effects. And so I certainly prescribe a lot of medicines to lots of folks struggling, and I try to prepare them for the possibilities of side effects. Some of these side effects can be transitory and short-lived and settle very quickly after kind of giving the body a chance to get used to the medicine. I also my default tend to start everybody on kind of low doses, starting gently and then increasing up to a therapeutic dose in an appropriate time frame. Don't want them on too little for too long, but long enough to get used to a side effect or get over a side effect before increasing the dose.
I will say the times that I've been in the room with you, and I know the other clinicians that have been in the room with you as well, would say that usually people are expecting something and they're like, oh, this is it? Like, when are we doing this? And you're like, well, it's over, it's done. And so I think sort of for our clients, it's the anticipation, it's the not knowing. For many of them, if not all of them, it is so challenging just to get here. And they might already be just very anxious and not knowing what to expect. And so I would say almost every single time, it's never really what they expected. It's always like a lot less than they expected.
And that's probably because I'm the one preparing them, and I'm probably a little
Right.
over preparing for some challenges. I don't want folks to be more anxious,
Right.
but you know, and I think some of the treatments that you've also joined for is after folks have also gotten used to it a little bit, and you know, they're receiving treatment, and so any of that discomfort, they've already gotten used to it, and
Right.
it really becomes something that folks will look forward to and kind of be, you know, eager, and folks are coming on time for their treatments. And so, you know, who's a good candidate? Who are we thinking about here? So, you know, if they have a diagnosis of major depression, if they're struggling with antidepressants, either unable to get into remission, so even a partial response to medicine, but we're not at remission. You know, I mentioned it with the patient I spoke to yesterday, kind of the range of emotion, which is normal and healthy. But the goal for us, and something we need to be thinking about, I'm always trying to think about, and we all have these patients that are happy to be a lot better. They are happy to be mildly depressed or satisfied, and even resign themselves to remain mildly depressed because it's so much better than the severe that they felt. And so folks that are struggling with mild depression are at a much significantly higher risk of a recurrence and a relapse to that severe than the folks we bring into remission fully. And so, you know, some of your folks that have just been struggling, I often think about a medicine change, you know, or the possibility of TMS. You know, when folks are stuck at a plateau, they're at a level that is not yet a level of wellness. There's continuous significant symptoms and impairments that are limiting wellness. And so just kind of thinking about the word remission, and that is our goal. So I have a slide here. Let me put this on. This is Joe Harris. She's going to share a little bit. Let me hit play here.
I think there's a special setting we have to do to have the sound play through your computer through Teams.
Yeah, I think.
Was this on or no?
I think the sound, you can hear it on your end, but we're not hearing it through the Teams chat or through the Teams webinar.
Is that something I need to adjust here, or is that?
Yeah,
That's okay.
that's a thing.
All right, let me see, or we'll just skip it. Is there a way to turn the audio on? Is that?
You can just skip it for now.
Skip
I
it.
mean,
Okay.
Probably if you went to YouTube, maybe.
No, just skip
Okay.
it. It's okay.
All right, we will. Sorry, just sharing of a positive experience. I will kind of move forward.
They looked happy. Thank you.
No, and you know, we've got, and that wasn't a patient of ours. That was kind of a patient through NeuroStar that had really responded well and was just sharing of the process a little bit.
I feel, you know, we have. Do you want to share a little bit about?
So I mean, I can share. Sure, I can, this is a little busy slide, however, to leave as kind of the default on here. So let me come back to here and just kind of, I'll jump over to that algorithm slide in a moment. I do have a little patient writing that was shared with me regarding their course of TMS and kind of how they were responding and how they were doing. Interestingly, you know, I'm talking about remission and the goals of getting folks into remission from depression and TMS as an option for that. This is actually a patient who categorically would be considered a non-responder because the scale scores had changed inadequately to show an objective change. But as we all know, working with folks, sometimes, you know, it is not about a rating scale score, but rather their experience. And so, you know, this was this patient sharing here. I can read a little bit, and this was the patient's writing. This was the patient's kind of letter, and sharing. The PHQ-9 scale may not show a full picture on how the treatments have been assisting me in managing my depression. The scale scores seem high, but the intensity of my symptoms has been more manageable since starting TMS. I have been suffering from depression for a long time and feel as if TMS helps and has helped me cope better with the symptoms. I feel as if the scores don't show the full picture. TMS has helped me with daily activities, lessening the symptoms of sleepiness and lack of interest. One of the main benefits I have noticed so far in this treatment is that my interests, which I haven't had in a long time, have returned. Although I don't expect TMS to be a magic cure, I personally feel as if my overall quality of life has been improving, even if it's a small amount. One huge improvement is my suicidal ideations have dropped off from multiple times a day to maybe once or twice and of a lesser intensity, and I'm able to cope with it better. The treatment has improved my day-to-day experiences so that I am functional, which is a huge improvement from baseline. And they go on to share kind of more examples of some of the other changes, able to exercise, to lose weight, able to work more shifts than what they were able to do before, socialize with friends and family, meeting deadlines and appointments, keeping a goal schedule, you know, multiple things that had changed. And so, you know, the TMS can be and has been a tremendous tool for so many folks. Let me jump into this next slide here. We're not going to do the video again. We're going to jump forward. And so, you know, APA has TMS listed as early as a second-line treatment. So kind of the American Psychiatric Association. And so first-line treatments are the standard SSRIs or SNRIs. Many folks, after a failed attempt with medication number one, would switch to an alternative antidepressant, which we see at the top here, either another SSRI or switching to an SNRI. Seeing how that works. There can be augmenting strategies for folks that have partially responded. That's always another interesting discussion. Also, if there's been a small change, you know, how much of a change, how much improvement is worth keeping a medication present, continuing it and looking to augment versus changing the medicine and starting over, looking for something, a singular medicine that's going to have a more full and complete response. So the augmenting options are here. Now, TMS can be thought of sooner than many are thinking of this, can move certainly, actually before we would get to anything like ECT, electroconvulsive therapy, or VNS, vagal nerve stimulation. I actually have another recommendation that I typically place in here before the ECT, which would be ketamine treatments, as that is now also another FDA-approved treatment for treatment refractory depression that hasn't adequately responded. I do have discussions with folks sometimes about TMS first versus ketamine, And really, and for me, it comes down to the side effect risk and the risk benefit. I think the potential benefits, the numbers are fairly similar for response profiles. However, the risk is a bit higher with ketamine for dissociation, derealization, hallucinations, which can be tolerated. They can be managed. A center that provides ketamine keeps folks in-house for at least 2 hours after each treatment in order to supervise and monitor and make sure that that they're back to their baseline before returning back to the community. The TMS is a treatment, kind of folks drive in, they drive out. It's about 20 minutes, sometimes a little bit longer, but generally 20 minutes per treatment session, and folks can kind of come and go. For the ketamine, for ECT, you know, folks are not kind of driving themselves in or out. They're not doing that on their own. The other piece here, you know, treatment, recommendations, guidelines, first line, second line. The bottom of the slide here, psychotherapy is recommended throughout. You know, a good therapist, somebody that is working with them, trying to help, you know, doing different technique strategies, whether CBT, DBT, other therapeutic interventions to try to help move folks from depression. You know, that is hopefully a continuous presence in their lives and something that they are doing the work to try to get out of that state of depression.
Which actually, Dr. Greenberger, brings us to something really unique and interesting about our practice, which is that all of our treaters, so we'll talk a little bit more about what the process looks like, but when the person is receiving the treatments, there is always someone in the room that is a master's level mental health provider. So whether they have their master's in social work, their master's in counseling, we always have someone, and not only do we have someone, but they stay in the room for the entire treatment. So when you think about that, if someone's coming in every day, 5 days a week for 20 minutes over a 6 to 8 week time period, I mean, that's developing a relationship with someone. Now, we don't do therapy with the patients when they're in the room, but we are supportive. We're a listening ear, and we really do build that rapport, so much so that you know, some people just like to come back and hang out. They like to come back and say hello. Sometimes our TMS patients turn into our therapy clients, not the people in the room with them, but we refer them to somebody else here at the center. And so it really is something quite unique. And I will say, as a therapist, it's a different kind of a relationship. So it's you get to know somebody in a different kind of a way, and you get to hear day to day how they're doing, how they're responding to the treatment, the really good days, the hopeful days, you know, the days that can be a little bit more challenging. But when you really are in the room with someone, it's a different kind of an experience with mental health. I'm sure we can all say that our treatment doesn't always move as quickly. And we don't get to see the benefits. So the other treaters in our center really tell me how much they enjoy doing TMS treatments, because they get to see that the change, which can be, for most people, so significant. You know, you could work with, I have some clients I've been working with a decade. I'd like to think I'm pretty good at what I do. But I'm like, what's going on here? No, I'm kidding. But I mean, it's really something extremely different. And I wouldn't say, I don't know, I think if I was listening to this presentation, I'd be like, okay, that's great. But because I've been in the room and because I've treated folks that have successfully finished TMS and have had such incredible results, to me, I'm very passionate as a therapist.
Absolutely. You know, our results here as a practice are a little better than the larger studies. And part of me believes that is because we have a master's level clinician individual in the room throughout the entire course of treatment. You know, some other centers, some other locations that provide the TMS, you're kind of, you know, you get a call button and a TV, and you're kind of more managing independently. You're kind of showing up and you're there, but you don't get that continuous support throughout the treatment. This slide here, we also talk a full course of treatment is 36 treatments. It is 5 days a week for 6 weeks, and then it comes down to, we have a taper for 3 more weeks of a 3, 2, and 1. Most folks often will choose about the same time every day. The treatment is typically in that 19-minute. It's been an infrequent occurrence. We have not had anybody up to 38 minutes, although I think technically that would be possible by the protocol. And the great majority are in that 20-minute time frame. Folks are awake, alert, interacting. We have some folks that'll listen to music. We'll have some that have played podcasts. I think more often here we have folks that are
Chatting it up.
Chatting it up is right. They're talking and they're enjoying the company.
Yes. But silence is okay too.
It is right.
And
It's not necessary. It's
Yep.
It's not an absolute requirement.
But you get up and you go back to work, you go back to school, you go back home, you go run your errands.
And so the pulses are, here they're kind of, we're kind of likening it to physical therapy. It's kind of opening up pathways in the brain, allowing for that neurotransmitter chemical release. I've got another slide coming up here that I think will be helpful. So here, the left side of your screen there shows these are PET scans, images of folks struggling with depression and non-depressed control groups, and doing the same tasks and looking for which areas of the brain become active with various different tasks. This imaging has been repeated with multiple different tasks and different illnesses, different states. And we can see the reduced activity here on the left side in the depressed brain, where a depressed individual's brain is not functioning in the healthy way, in the way that a non-depressed brain would function. And so with treatment, whether therapy, medicine, TMS, or other treatments, when that individual is no longer depressed, their brain functioning and chemistry will return to that non-depressed brain's functioning. They've looked at this across various scales and different areas of treatment. It is not about which treatment somebody uses. This is not an effective medicine. This is not merely the effect of TMS. This is the effect of a treatment that is working to move somebody out of the depressed state and into that non-depressed state. The non-depressed brain works better and in a healthy way, where a depressed brain is not functioning properly. And so what the coil is doing, so this is kind of the magnetic coil is in that NeuroStar handle there, and it is releasing magnetic pulses, very rapid pulses to a region of the brain, causing a depolarization of neurons and eliciting action potentials, releasing neurotransmitters within the brain.
I'm going to interrupt you for 1 second, and I'm
Sure.
going to say, if anybody ever is around and they want to pop in, we would love to have you. We could show you. People always think it looks like a dentist chair. I don't disagree, but you can, anytime you want to, I'll put my email at the chat as when we come to an end, and either myself or one of the other clinicians would love to show you around and to show you the room and answer any questions. I wish we had a picture of it in action, but that would be weird. But we would definitely love to welcome you anytime you wish to pop over.
And so the coil itself is delivering magnetic pulses to the left prefrontal cortex, the dorsolateral prefrontal cortex, causing a local neurotransmitter release. And that's kind of the color shapes that you're seeing here near the surface of the brain on the outer region of the brain. And what that then does is cause a cascading release of neurotransmitters for deeper brain structures, limbic system structures, and it is this deeper activation that is felt to be helpful for mood circuits and for helping to lift the depression. It is not merely the more superficial brain regions that are being enhanced here. The signals, the magnetic pulses, are causing a cascading effect to deeper brain regions, and being in the right location, knowing where to deliver those pulses, is what we figure out on the first day of treatment. and it is this activation release chemical refreshing, if you would, that is helpful for the treatment of depression.
So everybody then has a unique spot, right? So my spot is not going to be the same
Slightly,
as yours.
there it is. Anatomically, it is similar. Now, different head shapes, sizes, you know, there are small differences individually, but we are looking to get to that region of each person's brain that is doing the same function.
Mhm.
And so there is a process to kind of figure that out on the first day.
Okay.
Yeah. But it is not simply it's not a simple measurement.
It's not like a one size fits all, but we'll talk about what that first visit entails.
And so here is just another imaging of that activation for the superficial brain region. You can see closer to the skull and kind of the outside world there, and then the deeper tissue activation release that is happening subsequent to and in parallel with the superficial dorsolateral prefrontal cortex release. So the treatment here, we're specifically targeting this left prefrontal cortex because that is heavily connected with the deeper limbic structures, and so causing this depolarization. Sometimes I explain to patients it's almost like a refresh button on your computer, causing a refreshing, a release of, you know, when we think about magnets, we think about things lining up, right? We think about kind of things being drawn to a magnet. And if we think back to chemistry, I may be going a little too far here. You know, all cells, atoms, there's electrons, protons. I did like chemistry.
You took a lot of chemistry. I barely passed chemistry, but this is good.
The kind of aligning, kind of pulling things, drawing things out helps in the release of neurotransmitters and helps to kind of refresh, recycle the compounds and the chemicals that are not being released and cycling and used in the optimal way, thereby kind of the brain is in that depressed state. So this is trying to bring them out of that by fostering a healthy release.
Is there any other sort of non-medicine or non-invasive way to do this? Same action?
No,
Right?
this is a unique treatment. You know, yeah, this is not like anything else.
Because medicine doesn't work this way.
Medicine
right?
does not work
ECT
in this.
doesn't work this way.
No. I mean, yeah, ECT is a global seizure that is being induced electrically within the brain to cause a full chemical release of every brain cell. This is a very localized.
Right?
Oh yes,
so
yes, we're not that.
Right.
Yes.
So this banter back and forth, right? So as a therapist, I went to social work school, barely passed chemistry, not a doctor. You know, I'd like to keep I know a lot about medicines because of you, but some of us don't have that same luxury and they have to go to CEUs to educate themselves. So as a provider, as a therapist in the room. We all
have to do CEUs.
We do. But you know, for us to
the medicines don't work in this fashion. This is a direct depolarization of brain regions in a safe way.
Right.
That is, you know, well tolerated. If somebody's gonna have a little discomfort at the site, that is the side effect. This is not something that is done through other. Right. It is a unique mechanism and a unique treatment that it's being provided.
Which for me as a therapist seems like a tool that I can add to my toolkit was really my point of things that if I'm in the room with someone, which I have a few patients now with COVID and lots of other life events are significantly depressed, have been on medicines, are really have been seeing me and feel they're never going to get any better. I feel like stuck. And just, you know, that this for us as a clinician, we might not have the same confidence to have these kind of conversations.
Sure.
And so I just want to put out there that I've, you know, this training and reading a few of the articles really gave me the confidence, and I think gives some of us the confidence to be able to have this conversation as a possible response.
Yeah, and just to be able to speak about it. I mean, this slide, you know, shows kind of a diminishing return with each antidepressant trial, kind of less and less likely for it to get the patient into remission and a greater likelihood of side effects with each trial. And so sometimes we do need to think beyond. And this is these are looking for remission, not response. The response rates are much higher than these, but I think the side effect rates are probably fairly similar. TMS is very effective in getting folks into remission and response. This is a slide. I'm not sure kind of where they pulled this study, kind of how severe these folks were, but the response rates for TMS are terrific, very high. These are remissions that we are striving for depression. So TMS now has come a long way. I shared of earlier kind of different barriers to care and to treatment. TMS is now a covered treatment for the great majority, if not all. We will work with all insurance companies. Collaborative counseling TMS accepts all insurance for TMS treatments. And if somebody has some small plan that we are not yet partnered with, we will figure out how to work with them to accept their insurance for this. We also accept Medicare, and we have worked with medical assistants as well. We will kind of work with whatever insurance. We don't want there to be a financial barrier to receiving this treatment. Depending on the individual's plan and their specifics, they may have to meet a deductible. You know, most plans do have a copay, but the rest of the treatment is being covered by their insurance, and we'll work with their insurance to get it covered.
I think also as a therapist, you know, access to care is such a challenge, whether it's very long waits to see a psychiatrist, very long waits to see providers. Some of us, because we're in person, we have a longer wait list. And some of us, I think most clinicians at this point are full. So I also like to think about
virtual and in person.
Correct.
Yeah.
I also like to think about this as something that more people have access to, because the treatments are shorter. You're able to help lots of people in one day, so you don't have to wait for this. We can get folks seen very quickly. They can get started with treatment within probably, I would say, a week of calling, if not.
Yeah.
What do you think?
I mean, so we had the most, you know, we had a call last Thursday. I did an eval yesterday, and we have a start date next week. So, you know, I think to
at least
a
to
few
see
days.
you.
Yeah, I mean,
Right,
yeah,
which we'll talk about what the
there's a few
process
steps
is.
in the process,
Mhm.
but we do try to move folks through. When someone is reaching out for TMS, they're struggling with significant symptoms. They're really needing help, and we're trying to kind of meet them where they are and kind of help them to receive the treatment if it turns out to be appropriate for them.
Mhm.
You know, with each treatment session, you know, folks come in, they kind of get settled, comfortable in the chair. The coil is kind of positioned and kind of placed back in exactly the location that was determined on the first day. The pulses are then delivered, and upon, you know, leaving, you kind of go back to your regular daily life activities. There are no restrictions before or after. Our process, kind of what we do initially, you know, somebody calling, we will either speak to them right then and there, or we will call them right back within a day, and they will be offered a free consultation, or do that right in that initial phone call, where we'll gather some information and see whether this would be something that might be appropriate for them. And if it is, they'll be scheduled for an evaluation with me, who can review their history. Really, I shared with this woman yesterday, not just a consultation for TMS, but even just another psychiatric assessment for this patient that was appropriate, is going to be starting with us next week. You know, I made another recommendation for her, interestingly, yesterday. You know, she's taking a sleeping medicine and was taking it at 7 o'clock at night and really not going to bed till much later. And I said, you know, maybe you want, you know, that one is really designed to make you tired. It was trazodone. And I said, you know, that's probably better taken 30 to 60 minutes before you're going to go to sleep. You know, if you want to reach out to your doctor or check with your psychiatrist, I don't think they would have a problem. You know, she said they never really reviewed exactly what time she was taking it. They say, you know, if you take it at 10 o'clock, I think it'll be more effective in helping you to fall asleep when you're ready and actually trying to fall asleep rather than taking it too early. So, just, you know, sometimes I'll provide, I'm always trying to think what else might be helpful for this person. Are there other small things, subtle things? So, you know, that's kind of a shift. That's not really a change in medicine, but that adjustment might be very helpful for just sleep and energy even before we get started with the TMS.
So after they call and can get information from one of our clinicians about what this is and ask all their questions, get all their information that they need, then they get a psychiatric evaluation, is what you're saying, in
Yes.
which it's not just, well, I mean, the primary goal is to assess
for
for the
TMS,
appropriateness of
and we
TMS,
have,
but you might get a little extra.
yes, I'm
I would
always,
argue that you're always getting a little extra.
always
I
try
don't
to
think
give-
you can help it.
No, absolutely. And you know, if I'm seeing somebody who is not appropriate for TMS, for whatever the reason, I'm always looking to recommend other things for them. And so, you
Be
know,
helpful.
one contraindication for TMS, one reason not to do TMS would be if somebody had metal plates in their head or metal stents in their head. You know, there are folks, you know, plenty of folks that have had different procedures, surgeries, aneurysm clips. If somebody has metal in their brain, this is not the right treatment for them. You know, magnets heat up other metal, and so we don't want to be heating anything up that's inside their brain. And so that would be somebody who is not appropriate for TMS. On that first day, we do what's called a motor threshold determination, which is where we are looking for that location, and we have a process where we do that, and we'll be looking for twitches in their right hand because there's a translation within the brain and neuroanatomy for where that is motor structure is located and where that dorsolateral prefrontal cortex is located. And there's a shift that we make after doing that. So we find the location. We also find the lowest energy level. And then during that first treatment, during that first day, they also receive the first treatment.
How long is that approximately, like start to finish?
So on the first day, you know, I'm still asking folks to set aside an hour and a half.
Okay.
Although we're generally able to do it in closer to an hour.
You are ultra thorough.
I like to give a little bit of extra time just in case, you know, sometimes it's a little tougher to find that sweet spot for somebody and to kind of get that exact right location. And I tend to be fairly meticulous in my approach. And so I just like to have extra time if I need it. So we ask them to set aside an hour and a half on day one.
So just day one, and then the subsequent treatments.
We'll know exactly how long each treatment would be during that first day. And again, the majority of folks are under 20 minutes.
Okay.
And then
do you pop in and say hello?
Sometimes I will.
you do.
Sometimes I will kind of
Okay.
pop in between patients or to say hello and kind of check on folks and see how they're doing. They'll also get a follow-up, you know, a couple of follow-up visits with me during the course of treatment in my office, just kind of seeing how things are going, how is this moving along, and also on the back end, kind of reviewing the progress and the gains that they've made, and if there's any other recommendations moving forward for them, depending on whether they achieved remission or were responders, or if they didn't get the response we were looking for.
Well, and as
And let me
therapists,
share actually, you know,
go ahead.
the percentages and kind of where we are statistically. I don't know that I have another slide here to show that. You know, in the larger studies, kind of the across the country looking at TMS, about 1/3 of folks get into remission with the course of TMS. Another third have a significant response and improvement with a course of treatment, and about 1/3 do not respond adequately. The excerpts I was sharing from that patient's letter was actually from one that fell into that non-responder category by objective measures, but clearly had also improved. And so depending on where they fall, determine, can affect recommendations moving forward. Folks remain under the care of their outpatient psychiatrist. Folks remain under the care of their outpatient therapists. We are not doing therapy during the course of TMS. I am not adjusting medications more than that slight shift in the time that they were taking their trazodone, in my example from yesterday's visit. And I will coordinate with the outpatient psychiatrist and team if there is a medication piece, somebody's having a significant side effect they share with me in a visit, and I'm concerned about, I'm going to reach out and talk to the doctor, talk to the psychiatrist that's prescribing it, and make a recommendation, let the patient know that I'm doing that so that they're not caught off guard. Occasionally, I see folks that are coming to me before they spoke to their psychiatrist. Sometimes it's a therapist that is referring them in. Sometimes they're finding us on their own, and they're coming to us without treatment in place. And so depending on their situation, sometimes, if they have a psychiatrist but haven't spoken to them about coming here yet, they'll want to reach out to the doctor themselves first rather than me being the one to reach out, or vice versa. So we will coordinate in whatever way we can with the treating providers. We are providing this course of TMS. They finish with us, they return to their outpatient therapist, they continue with you during their course of treatment, and they continue to work with their outpatient psychiatrist for medication management and adjustments as well. They can choose to implement any of the recommendations or adjustments that I might suggest along the way. But I try to, keep those simple and coordinate with the doctor if I think we need to do something differently. And so Emily has been sharing her therapist point of view throughout. So we've kind of already been doing that. This is our team. Myself, we've got Emily, we've got Hajan, Marley, Avneet, and Gabby, all participating in the care and keeping and treatments of our TMS folks. I don't think we're going to show this story either. The other one didn't work properly, so we're going to kind of leave that off. Is there an ending slide here?
Just pause it.
And so other safety issues, I shared the issue with metal. The other rare risk would be of a seizure. That is extremely uncommon. Perhaps 1 out of 10,000 patients might experience that. That is not what we're looking to do. For those cases where that has been reported, it is a 4-second seizure. It is during the 4 seconds of pulses, and it immediately ends and stops as soon as that sequence of pulses ends. The pulses come in 4-second intervals. There's a 10-second delivery time frame, kind of a rest period, and then another 4 seconds of delivery. Extremely rare, but is in the literature and would be the other extremely uncommon event.
So I know we're talking about the treatment of adults. So can you talk a little bit about the age of your patients, and what are we seeing now post-COVID era in terms of who you might?
Yeah, I mean, I can. Yeah, that's nice to bring that up right now. So, I have board certification in child and adolescent psychiatry, also in adult psychiatry. I treat everyone across the age range. And for the TMS, we have treated geriatric patients. We have also treated teens. We have been able to get insurance coverage for teens struggling with depression. I have also treated folks with a bipolar depressive process if they have failed, various other interventions. This is a treatment for the state of depression. The current FDA approval is for major depressive disorder. Insurance companies are covering this for 18 and up on the surface. Those other cases, the teens or somebody with a bipolar process, did require additional back and forth to get approval with insurance companies. If we our team and the patient's outpatient team are in agreement that this is a good treatment course, that this would be appropriate to try, I will do whatever I can. I will go to bat with the insurance company to argue and to get that covered for folks if we think this is really the safest, best option for them. Interestingly, also for the teens, you know, I think, not I think, so I expected there to be an approval for TMS coming for teens. There was a study going on for an extended period of time, and unfortunately, it is not going to get approval for teens, because the irony is that too many people got better. Yes, it's like, yes. By going through the course of TMS, the responses were much better, and in addition, the placebo group also got better. So everybody got a lot better, and so there were other factors that were obviously contributing, and whether other supports that were being provided, so it didn't separate enough. But the short was that too many people improved for it to show itself to be cost effective. And so and right now it's very hard to do more studies. So many folks are struggling. You know, I think they need to figure out how to minimize that risk of over response to the sham treatments, is where folks are sitting and they're having a sensation that is not actually a magnetic pulse being delivered. But too many teens improved. But
if I have a client who's 17, who I think would really benefit from TMS, we still could go to bat for them, correct?
Yes, absolutely. And most of the insurance companies will now approve that as well. If they have tried the insurance company's number of medications, they've tried therapy, they also have to try at least, depending on the insurance company, a 3 to 6 month course of therapy before the insurance would cover TMS.
So I don't know, but interesting. We're going to get to the questions in a moment. How many therapists have actually referred clients to TMS and have experienced it? I can speak to experience for one patient in particular who could not take any medicines because of, I don't really understand why, but there's something about their genetic makeup or how things just work in their body, but their body was adverse to any medicine that was tried.
Side effects, yeah.
And lived a very secluded, you know, life where they could not function, could not finish school, could not work, could not go out. Did a course of TMS, and it's been about almost 2 years. And they are graduating from college. They're becoming a teacher. And it was life-changing. And when I was in the room with them, I continue to feel very ineffective, that there's limits of psychotherapy because the biochemistry of things, there just is limits. And if this person is about to go out into the field of education, it's just, I mean, one of the most powerful stories for me to see.
So those of you that have referred folks or seen folks that have either responded well or not responded, or gotten partial responses, hopefully this is something that each of you get different experience with over time, referring folks for TMS when you've got folks that you think are appropriate. And it is something that is becoming more commonplace and more easily recommended. One of the goals for us today was to help you to become more familiar with it, what it really is, what it entails, what it would mean for a patient if you were going to refer a patient for TMS.
And I think as what we've seen anyway in our practice, I'm sure all of you can agree, this generation anyway, the destigmatization of mental health allows us to have conversations about interventions for mental health that are different from what we've known, that we've been doing this for so long, that there are new innovations and there are new interventions that if at first we're skeptical or we don't know, that at least hopefully after today that this is something that you say, it's like a little aha moment, like, okay, well, let me look into this a little bit more, or let me learn about this a little bit more. So with that,
Let's
I
give
don't.
some time for questions.
Yeah, I
and
would love to
if,
see what we have in the chat. So I think someone was going to help moderate, and if we can break this down,
Sure.
so
Yes.
you're more of a
I'm gonna
person.
come back to
God,
my
I've got
notes
them listed
here.
up here, so
Yeah.
I'll just go ahead and start with the first question that came through. Was, can a client with NeuroStar start with it if they have not tried antidepressants already?
Most of the insurance companies are going to want at least a single medication trial. Yeah, now that being said, whether, how long of a trial? I think Emily asked at the beginning, what is a trial? What does it mean to have a trial? And so, if they did try something and had significant side effects, they don't have to stay on it for months. But I don't know of an insurance company that's covering with 0 medication trials.
Sense to me. Samantha asked, is part of treatment brain scans before and after the TMS treatment? For instance, it would be lovely if we could have that, but and what is the youngest age? And you address that also.
Yeah, so I mean, I wish that we could, and there are some research facilities that are trying to do some scans, during treatment, at the outset of treatment, on the first day, helping to localize and find that sweet spot, finding that right location under PET scan imaging. This is, at Mayo Clinic as part of a research study, and what the studies have shown so far is that really we can do a fairly good job approximating getting nearly that same accuracy with the methods we're currently using. It is not something that that folks are paying for. Those are not typically scans that we get outside of research capacities right now.
I'd love a PET scan of my brain. Catherine asked, you mentioned depression, and then you also addressed bipolar disorder or mania. Just to go over that again. And you mentioned that there would be additional approval, but how have you seen treatment of those affected?
Absolutely. So let me start with bipolar disorder, kind of the manic depression. So when someone is struggling with bipolar disorder, they can either be in that manic state, they can be in the depressed state, or they could be neutral. They could be kind of in a euthymic kind of stable state. So for a bipolar process, if somebody is having elevated symptoms, any elevated symptoms, manic symptoms, hypomanic symptoms, or mixed, if they're having a mixed state where they're experiencing both the ups and the downs simultaneously at the same time, then TMS would not be the treatment that we would be looking for. Really, the TMS would be something we could consider for someone that has a bipolar depression, that is a depression that they have been stuck in despite trying various other things, medication adjustments, changes, in order to get out of that depressed state. And we see this. We see folks that get stuck in a depression and they can't get out. I have treated a number of folks with a bipolar depression process, and we've been able to get them out. One in particular who, so the risk with TMS and somebody that has a bipolar process actually is that we could pull them too far. We can kind of bring them out of the depression and cause a mania, bring them into a hypomania, and kind of go too far in lifting. We could lift too much, which is a similar risk that an antidepressant would have in someone that has a bipolar process. It's bringing them out of that depression. Now, I think the benefit for us and what we were able to do for this patient in particular is that there's a master's level individual in the room with you for the treatment every day of treatment. So, there's somebody else who also has a sense of that and is following that. And in somebody that had, in this individual, we all knew that he had a bipolar process. There was discussion, there was an identification, and as soon as he started to feel a bit better, even a little bit, maybe a couple of symptoms that felt like maybe they would be on the edge, we reduced the frequency of his TMS. So we altered the course. We did not do 5 days a week for 6 weeks. It was in the 3rd or 4th week where we reduced him down to 3 days a week and then 2 days a week. And so he actually had a full course. Towards the end, he had come in for 1 treatment every 2 weeks. And so it was a very, very
Tailored.
Yeah, individually tailored course in order to maintain well. And he stayed in remission at least I lost contact after a bit, but it was at least a year he was still in remission after that course of treatment.
Related to that, depression, TMS, and how it affects bipolar, are there any other mental health disorders that are coming out that TMS might be effective for?
So that's a great question as well. So there are some treatments for OCD now that are seeming to be helpful. They're also looking at it for certain positive symptoms of schizophrenia, actually, looking at it to help abate. These are not, that's not FDA approved yet, but they are looking at it. There are also some treatments. It's a different location. They're looking at TMS, magnetic stimulation for treatment of migraines also, actually. But it's a different region that's being activated for the treatment of migraines.
Thank you. Catherine asked, for individuals who see positive results from TMS, how long does it usually last? And this is fairly new, but and how often do they need to return for courses of treatment after a period of time to maintain those results?
Also, and also I mean, it's been around for a long time, TMS. So we do have some data, long-term data for folks. What I also share, so when we get folks into remission, whether through therapy or medication or TMS or whatever other intervention, I think we've all had many of us, if not all, have had those discussions. What do I do now? Now I'm well. I'm in remission, and so the goal is to stay there, right? We want to stay well. And so for the TMS, this is often the great majority of folks are coming in, they're on medicine, they're taking something that's helping, they're having a partial response, it's better than nothing. And we're adding the TMS as an additional treatment on top of whatever else they're doing. They're going to keep with therapy, they're going to keep with whatever medicine has helped, even 20%. I don't want steps, again, I'm risk averse. I don't want steps backwards. I don't want anybody worsening. So what I can share with you is that for the folks that get into remission, and this is where there's probably the most data, it's a little clearer to observe. The folks that get into remission, it is recommended that they remain on the same medication regimen that they were on during the course of TMS for at least a year. What we know is the folks that stop within a few months, folks that stop something that they were taking, they feel like the medicine never got me there all the way. It helped me 30%, 40%. The TMS is what got me into remission. And so I don't need the medicine anymore. Those folks, unfortunately, are at least twice as likely to have a recurrence within the first 6 months. It's nearly 50% of folks that stop an effective treatment that will relapse within those first 6 months. For folks that stay on their medicine, that stay on the regimen, that continue with treatment, 80% of them remain in remission at 1 year. That's really very good data. With depression, there are risks of recurrence. Major depressive disorder is a recurrent problem for many. With each episode, there's a greater risk of another recurrence down the road. And so we have also treated folks that have had multiple episodes, that have had what I share with folks that get into remission also is that if they find themselves experiencing a relapse and a recurrence of their depression, whether a year out, 5 years out, 10 years out, if the TMS was effective in getting them into remission, it would be likely to be effective again. And so we've had folks that did TMS in other places and found us after being here in Maryland and responding again to a second course. We've had some folks that have received a second course from us, the first and second from us. And what I can tell you they also share with me is that typically the second course, if they had got into remission the first time, works even a little faster than that first course of treatment. And whether there's kind of a brain readiness and kind of ability to receive it that is a little bit smoother. But so that hopefully that answers the question.
That's wonderful. Thank you. Just
Sure.
as a reminder, it's 2:17. We have you till 2:30, but we do have about 5 to 7 minutes worth of, maybe not even 7, but 5 minutes of things. So I have 2 more questions that have queued up. I'd like to get through those if we can, and then have time to. Awesome. Thank you. Joshua asked, any experience with SNT, stand for neuromodulation therapy, modulation therapy, or SAINT protocol treatment?
Yeah, the SAINT protocol. I have read about it. I have looked into it. Basically, what this is, it would be very hard to implement here. It's not something that I am able to implement, but what it is basically it is folks coming in for a matter of a week and sitting in the chair for 8 hours a day, 5 days, for 5 days in a row, kind of a continuous course of TMS, kind of ongoing, like for an intense period. They've done that for folks that are struggling with more severe symptoms, and it has shown itself to be helpful. The results look very good. It is not something that is generally offered in the community right now. I think you do need to be through a teaching center or a research facility, but I have looked into that, and kind of it's very interesting to think about. You know, that here, you know, you would be limited to one person receiving treatment at a time with per machine.
Definitely more of a facility type service, I can imagine.
Yeah.
Another question I'm coming back to, I'm going to say Nana, but it might be Nana, I apologize. Are SNRIs more effective in treatment depression than SSRIs? I think that that was a question that came through based on your.
No, I don't think they are. I think the slide maybe were showed. I think the SSRIs were a little bit more effective, and I think part of a big part of that is that they have been. They're the first line most often, and so when we look at, so I think I had the remission slide up there. When we look at responses, when we look at the response to the first antidepressant that somebody tries, about 70% will experience, you know, clear significant improvement. That is not remission, that is response. With each ongoing trial, there's a reduced likelihood of getting into remission. So, you know, whether the SSRIs are, I mean, they are the more often first line treatment rather than an SNRI. And so whether that affects their global response rates being a little higher than the SNRIs because they're tried first, and that first try tends to look better than the second or third try. When new medicines are coming out, when new medicines are being studied, they typically are being studied for folks that have had other difficulties. They are not being studied in folks that have never tried a medicine before. Here, try this brand new medicine that we don't have data on yet. And so, you know, that probably affects those numbers a little bit as well.